Better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Welcome to the Untethered Airway Health Podcast. I'm Dr. Liz Turner. I'm an airway-focused dentist, mom of two, and someone who believes deeply in informed decision-making when it comes to our kids' bodies. Today, we're diving into a comparison that you've probably never heard in a pediatrician's office, but one that deserves a real conversation, in my opinion. Circumcision versus oral ties. Why is one considered so routine and unquestioned, while the other, despite affecting feeding, growth, and development, is often ignored, minimized, or outright denied? So let's start with what's considered normal, a circumcision. I had to do some research on this because, I have a boy. I was invited to watch the circumcision, 4 a.m., post-delivery. In the U.S., newborn boys are frequently circumcised just days after birth, sometimes even hours, before families have had a real conversation about the why. And today, it's just seen as routine, but the history behind circumcision is anything but medical. Again, I had to do some research on this because it's not something that I had just living in my brain, but it's been on my mind for a while as to why, and it was brought to my attention mainly by some of the pediatricians' children that I've treated or other providers' children. I had one doc in the other day and she came in for a growth check with her kiddo. He's doing amazing. He's 3 now. We treated him when he was a baby. And she goes, I remember being so tearful and scared and not understanding. She goes, but I circumcise children every single day in my practice without a second thought. So originally circumcision was performed in religious and tribal contexts, most notably in Jewish and Islamic traditions, as a rite of passage or spiritual covenant. But in the United States, circumcision took on a really different role in the late 1800s, early 1900s. And this, again, I had to look up, but it was during a wave of Victorian-era moralism and hygiene reform. It was considered a hygiene practice. It was promoted by doctors like John Harvey Kellogg, yes, the cereal guy. As we know, cereal and grains are under so much controversy and scrutiny and have been for the last number of years. He believed that circumcision could prevent masturbation and curb immoral behavior. So this was mainly what somebody thought could be beneficial that we based everything we do on. It was even recommended as a treatment for everything from epilepsy to bedwetting. So where's the science behind that? So then came the hygiene movement. In the early 20th century, as hospitals became more standardized and childbirth more medicalized, less home birth, circumcision was seen as a way to promote cleanliness and what was considered modern parenting. So by the 50s and 60s, it was so normalized in American hospitals that many parents didn't even realize that it was an optional practice. And so this is where it starts to get really interesting. Despite the long-standing cultural momentum, the American Academy of Pediatrics does not recommend routine circumcision. They say the potential benefits do not outweigh the risks enough to justify it as a blanket practice. So yes, let me repeat that. The AAP does not recommend routine circumcision. The potential benefits do not outweigh the risks enough to justify it as a blanket practice. Yet, it remains incredibly common. Again, so my son was born, was in the hospital. My pediatrician woke me up and was like, it's time. And I was like, okay. And I signed the paper. I didn't really think about what was occurring and what we were doing and what we were doing it for. Because again, having been so normalized and being a female myself, I didn't really understand what we were doing on my newborn boy. And so it's a surgical removal of tissue on a healthy newborn. It's performed preemptively, not because there are any symptoms or because something is wrong. And most people don't even bat an eye. And so now let's go into my favorite subject, oral ties. And this is what I really am passionate about. And this is the soapbox that I may die on. But I will continue to go to bat for families when they have been asking questions of providers and not getting answers. And unfortunately, because of the commonality of oral ties and oral dysfunction, this is a soapbox I'm going to have to be on for a very long time, because there's so much misunderstanding about the what and the why behind oral tissues, and what is considered tense, what is considered a symptom, what is considered proper treatment, why do we do treatment. But regardless, let's just talk about like what tethered oral tissues or tense oral ties can do. So tongue ties, lip ties, potentially buccal ties. These oral restrictions are structural limitations in the soft tissues of the mouth. These ties, they're restricting normal range of motion and functional movement of the tongue and lips. So yes, everybody has frena. Those are normal connective tissue structures. There are 7 of them in the mouth. 2 buccals on the top, 2 buccals on the bottom, lip on the top, lip on the bottom, and under the tongue. When they're too tight and restrictive, they get this terminology of ties because they're causing symptoms. If they don't cause symptoms, they're not considered ties. Sometimes I question if we're even really looking for the right symptoms. If we're seeing something that's tied to the tip and we're saying there's no symptoms associated with it, I'm not sure I believe that fully. I think we just don't know what we're looking for. So again, that's where interdisciplinary care comes in. We need functional providers to assess for. We need manual therapists to assess for residual body tension, torticollis. The American Academy of Physical Therapy recommends screening for and treating torticollis within, I believe, the first few weeks of life. I think they just updated their standards because torticollis, or tension in the body, has an impact on feeding in itself. So maybe it's not the oral ties, maybe it's the body that's tense. But until we have an interdisciplinary care team and until pediatricians feel really comfortable in making these referrals, we're going to keep seeing families that are dismissed and gaslit. And so again, ties, they're present at birth, they restrict range of motion, they lead to symptoms. That's why we call them restrictions. And that's why treatment is recommended. Unlike circumcision, oral ties have immediate and long-term functional consequences if left untreated when there's symptoms present. So here's what they can impact. Many times we're seeing children for feeding in infancy because babies with oral ties, they often struggle with not only breast, but many times bottle. Many children we treat are coming in because of difficulty with taking a bottle. And many of these moms are trying to go back to work and they're unable to. They have to extend their leave. They have to figure out ways that they can get home. This is really challenging on a family. So it's not just about breastfeeding. It's about medical feeding in infancy. They can also have an impact on nipple discomfort, a shallow latch, poor milk transfer, frequent feedings, clicking or smacking noises, reflux type symptoms, gassiness that is exacerbated by air intake when we're not creating a great suction or vacuum. That can also lead to a decline in supply. Again, many times we equate going back to work as the reason supply dips. Many moms go back to work around 3 months. At 3 months, there's a hormonal shift that occurs where breastfeeding in the first 3 months is driven by hormones. After the first 3 months, it's driven by supply and demand. So say we have this baby, a shallow latch. Mom's been using a nipple shoot because it was given to her in the hospital. Nobody recommended further support. They said, here, this works for you. Well, that baby likely is not creating an excellent vacuum or an adequate vacuum to sustain the amount of milk that needs to be produced. So milk isn't being removed. Milk will not be created. We also put a big emphasis on sleep training in our society. Why isn't your baby sleeping through the night? We have a program for that. Why isn't your baby sleeping through the night? Mine is. There's all these just kind of comparisons that parents are forced to make. When we have babies that are sleeping through the night when they're 2 months old, that's a red flag to me that either they're not getting fed enough, they're not hitting some of the milestones that they need to, and there could be a substantial dip in supply because that night nursing or night feeding, night pumping is really important to maintaining supply. So it's not uncommon for us to treat babies 3.5 months in when supply's tanked for a variety of reasons. And so that's where bottle feeding, breastfeeding, it can be inefficient, it can be exhausting. We have babies that are having a hard time staying on the curve. And so they go in, they see the pediatrician 2 weeks, they see the pediatrician again 2 months, and they've tanked in weight, they're down. And there's this kind of fear tactic that goes in these conversations of, well, they're falling off the curve. You need to triple feed. You need to feed more. You need to use an 8-ounce bottle. It's really, really tricky when we're making recommendations for families when we don't really have the knowledge to do so. And so then let's talk about transition to solids. Oral tied kids, they could gag easily. They could pocket food, avoiding certain textures, becoming more picky eaters. So often we hear, well, let's see if it affects speech. We've got a kid tied to the tip. We're going to see if it affects their speech. We have missed many gross motor and feeding milestones if we're waiting until 1.5 years and we start to notice there's a speech delay. Is there a speech delay? Is there oral restriction? How are they doing with solids? Have we created an environment where a child has had a dysfunctional swallow pattern for so long? It's going to be extremely difficult to correct at 1.5 years old. So we find children that because it's 6 months, they're introduced solids, sometimes even earlier, 4 months, rice cereal, not awesome for the gut health. If we've got kiddos who are putting solids in, but they're unable to create that bolus, they're unable to clear the cheeks, clear the lip, clear anything in their mouth, they're going to either pocket food, spit food out, have difficulty transitioning certain textures into their digestive tract. That peristaltic motion, that peristaltic wave is really disrupted. We're going to see kids start to gravitate away from certain textures, and it's not because they don't like it, it's because they're unable to tolerate it. How many of us as grown-ups have an aversion towards certain things? Struggle with dental x-rays because there's too much tension on the floor of the mouth. So that when moving food laterally across the mouth, if we're unable to do that with the proper musculature of the tongue, feeding is extremely inefficient. It can be exhausting. And so again, we'll see kids, and this is really heavily marketed. We've got pouches, we've got melt-aways, we've got purees. We've got all these avenues to keep our children fed, yet at the same time, they're not using the proper mechanics to do so. And again, it's not necessarily because there's a tie, but oftentimes a tie is going to lead to a lower musculature and inability to move a bolus of food. So of course it's going to impact feeding in some way. And finally, we've got speech development. So tongue ties, they can make it hard to elevate, lateralize, coordinate speech sounds. I have grown-ups come in often, they say, my speech is just not as crisp as I would like it to be. And you could hear in me, you're probably listening and saying, well, she's got speech issues. I sure do. I have a palatal expander in, meaning I have a metal appliance that goes across the roof of my mouth to create more oral volume and nasal volume as we get skeletal expansion. But one thing that you can hear from me is it's hard to create crisp sounds. I can say things, I can compensate. There are particular letters for sure, G's, K's, where I have to put more emphasis on what I'm doing. I have to work harder to articulate those sounds, and they still don't sound awesome. So we treat a lot of children that are in speech therapy. Of course, that's a difficult thing to study. We have many people who are naysayers of oral ties because there's not enough research. Well, the hard part is if I've got a kid who's tied to the tip and they're struggling with feeding, no family or provider in their right mind, ethically, is going to delay treatment for 5 years to determine if that oral restriction causes a lateral lisp or some type of speech dysfunction. So it's really hard to isolate these cases and say with certainty, oh no, that was never a problem for you, or that's the only problem for you. So what we have is we have cases, and we have people that come in all the time with difficulty with articulation and speech. They're not making progress. They've been in speech therapy for many years. Oftentimes they've transitioned to a new speech therapist because they're quite frustrated. They haven't made the progress they'd like to see. And a new speech therapist, just because of new training or because of their own personal awareness, they say, oh, there's a tongue tie here. And these parents are frustrated because it was oftentimes mentioned in early childhood, many times not. But if it was mentioned in early childhood, saying, let's see if it affects your speech, you still have parents that have been in the speech system for many years, and they're frustrated of, why didn't we treat this earlier? And we look at the symptom list and they say, well, we had these 5 symptoms too. So finally, my favorite thing to talk about, craniofacial growth and development. Why do I as a dentist care about oral restrictions and what they do? Because they have a huge impact on craniofacial growth and development. The tongue is a muscle. The lips and cheeks are muscles. This operates as a system. So I think it's really important to look at it as an operating system. I tell families the lips, the cheeks, they're like the door to the car. If they're stuck shut, you can't really operate the vehicle. But the motor of the car, the tongue, if that is not working well, you are not going to drive that car anywhere. We can compensate, we can climb through the window, we can get around those tense lips, but we're never going to drive that motor of that car as well as it should if it's not operating as well as it should. So systematic treatment of these, looking at how the functionality is impacted by tense lips, tense cheeks, along with a tight tongue, it's really important. So the tongue is nature's expander. The lips, cheeks, nature's braces. They're meant to be more passive instead of tense. We want to have an outward pressure of the tongue against the roof of the mouth, the palate, to drive the growth of the midface and to put pressure on the base of the skull in order to get that front to back growth that we need to get in that first 6 years of life when most growth is occurring. And it also helps to drive the growth of the lower jaw. When we have this tongue extension in infancy, what happens is it applies pressure on where the jaw joint is, and it forms the base of the skull, and it forms and lengthens the jawbone. So when we think about an overbite, it's often because the maxilla is narrow, the upper jaw is narrow, the lower jaw is tucked down and back. And many times if we look closely at the details of these cases, we'll see that there's tension under the tongue, never allowed for that functionality to happen to drive that growth in the right direction. So what do we see? When the tongue is tied, the tongue will sit low, the muscle tone will be low, and the maxilla or the midface, including the nasal cavity and the sinuses, don't develop as well as they could. So what's the result? We get a narrow jaw, narrow palate, dental crowding, longer faces, and ultimately airway compressions in the nasal cavity and behind the base of the tongue. So what happens then? It can lead to issues with sleep and breathing. Kids with, anyone with a short tongue frenum is at a higher risk of a narrow maxilla. It's an independent risk factor for that. It's also an independent risk factor for tonsil and adenoid hypertrophy, so enlarged tonsil and adenoids. So kids with oral ties, they often become more on the mouth breathing spectrum, especially during sleep, as our body is in a really pivotal state called REM sleep. The muscles go into paralysis, everything drops down and back, including the tongue. We have excess tension there, pulling it down and back instead of allowing it to sit up and forward into the palate. We're going to run into issues with sleep quality. So tongue posture is affected, oxygenation of the entire body is affected, sleep quality, and behavioral issues. Kids may snore, they may grind their teeth, they may wet the bed, they may toss and turn, or show signs of ADHD, ADD that maybe we're not addressing in giving a proper diagnosis when we're not looking for the root cause of what's causing these behavioral issues. So children, when they don't have they have poor quality sleep, they don't have the quality sleep that we need to get that brain restored and rested, we will see an impact on behavior because that's how it manifests in children. Adults, more likely to fall asleep at the wheel. Children, more likely to be hyperactive, irritated, have difficulty sitting still. And we'll see children that are grinding, have higher decay rates. All of this from a piece of fascia, in part, under the tongue, that many providers say still looks fine. But when we're not addressing the symptoms and the long-term impact, that's where we run into problems. And so here's where it gets a little bit uncomfortable. And again, going back to circumcision, I watched my sons. It's a pretty barbaric procedure, if you ask me. We've got a whole bunch of equipment out that I've never seen before, and it looks kind of medieval. You've got lidocaine, so there's an injectable going systemic. Of course, it's safe for use, but if we could not have to do it. And then in my son's case, they use Sweeties, which is a sugar water. And so I've got a kiddo who's 2 days old, and we're putting stuff that's not supposed to be into their system. And we can get a lot of microbiome gut dysregulation from stuff like that. So without really thinking about what's occurring, we've got a kiddo who's going through a removal of tissue for no real medical benefit, and they're getting extraneous substances put in their body. And of course, it'll help calm them. We know in the literature that Sweeties is extremely effective for pain management. But at the same time, why are we putting them through the pain? In my practice, I choose not to use Sweeties with Tise releases. I feel very strongly that the microbiome can be affected by those little things, especially in a young child, an infant. And I would choose to have a child self-soothed by a calm parent or calm myself, and trying to get breast milk, which has some analgesic properties in, to help soothe that child versus introducing an extraneous liquid that can have an impact on gut health. So circumcision, it's surgical removal of tissue from the tip of the penis. It's performed without any functional impairment at the time. It's routinely done despite neutral or mixed medical guidelines. How many of you as parents were spoken to about the AAP does not recommend this routinely? Would you like to do this elective procedure? Here are the risks and benefits written down and gone over with you verbally. Because in my opinion and in my practice, when it comes to oral restrictions, we talk through risks, benefits, controversy, recommendations, and consent, written and verbal. I think that's where this medical model is a little bit messed up, because we are holding people to certain standards, yet we're not holding ourselves to that standard. So then, oral ties, restrictive tissues, they're actively interfering with breathing, feeding, and growth. They're not treated routinely until parents are fighting for a diagnosis. Again, oftentimes I'm the fifth, sixth opinion somebody's got before they come in. And at the end of the day, and this is going to sound bad, I don't care what a family does, because whatever they choose to do is the right decision for their family. So what I tell families is, I want you to do what you feel is best for your family. You know your child, you know yourself better than anyone else. Here's what I'm seeing structurally. Here's what I'm seeing functionally. Here is what could be an impact long term. Here is what could be improving short term. So I try to be as clear and transparent as I can with families, to be a voice of clarity, to allow them to make what decision they would like to make. My practice, it's a referral-based practice primarily. So many families are referred over. They still are a little bit confused when they're coming in, and that's okay. We work with so many wonderful lactation consultants, manual therapists, other functional therapists, but still when they come in, they still say, I'd still really like your opinion. And I say, I'm going to give you my unbiased opinion. I am going to, of course, take what your providers have told you and weigh that into our assessment. But at the end of the day, I want you to make the best decision for your family that you feel the most comfortable about. Because babies with tongue ties, they grow up into children and adults with tongue ties. If we really put stuff on paper and say, narrow maxilla, higher risk of sleep apnea, higher chance of earlier death 10 years before, we could say that this is a life-threatening condition. I'm not going to go there. I'm going to tell families that this is not a life-threatening condition. I'm going to tell them this is a quality of life condition. If we are to look at the details of feeding, speech, breathing, growth, sleep, we can see an impact in all of those through restrictive oral ties. So yes, it will not impact somebody from ever learning how to eat anything. They'll just do it with compensation. Same thing with speech. They'll learn to speak. They'll just do it with compensation. The longer this stuff goes on, the harder it is to correct. Many of the adults I treat are very, very frustrated that nobody brought this to their attention, or maybe it was brought to their attention, but nobody said, this is going to impact you in this way. Because I treat a ton of people with chronic headaches, TMD pain, head, neck, shoulder tension. And these families are frustrated with the conditions that they've lived with for a long time, because though they're not killing them, they are debilitating to them in some way. And so if we're stacking the risks and benefits side by side of oral tie release and circumcision, the difference is striking. There is far more functional impact and long-term risk in not treating oral ties that are causing issues than in not circumcising a child. And of course, no judgment on circumcising your child. I just told you that mine is circumcised. I just really wish I'd been able to make a better informed decision about what was going to occur. Maybe I still would have done it. Maybe I would have denied the sweeties. Maybe I wouldn't have done it. I don't know. I can't go back in time. But I can go back and say to myself, I wish that I'd been better informed as a parent, especially a new mom who really knows nothing about what we are doing and why. So, but why are oral ties so controversial? And circumcision, it's just hardly mentioned. It's routine practice. And why is it? Is it cultural familiarity? Is it medical training gaps? Is it because of insurance, billing, and coding? I have no idea how much a provider gets for a circumcision. I can tell you the amount that we charge for oral ties is likely a fraction of it. I know that what we charge as dental providers is a fraction of what is charged in a hospital setting for an oral ties release. We're talking thousands versus not. So again, I mean, I've had families come in. I had one last week. She said, I'm just so disappointed in the medical system. I have a child, they're 3 years old. I am now needing to sedate them to do these ties releases because nobody looked in the mouth. Yet we've had tens of thousands of dollars in therapies, in testing, been sedated multiple times for different tests. And I had a provider when the child was young say to me as a parent, not me, but the patient, they said, if you want to waste $700 with the dentist, go ahead. It's not going to help you. She goes, and look at us now. And she was just so disappointed. And there's not a day that goes by where there's not tears in someone's eyes. And it's frustrating for these families. And I get it because they just feel like they've been asking questions for so long and they've not been getting answers. So I have no idea what they charge. I'd be curious to know. So if anybody knows, please let me know, because this would be an interesting add-on to this episode. But maybe it's just easier to support something that we've done for generations than to advocate for something that we don't fully understand. And that's where I really want to applaud moms and families, because they are diving deep into details, even if they're not getting them from their medical professionals. The conversations that moms have now are so different than what we had 20 years ago. We're more supportive of each other. We have more access to each other through social media, which is pro and con, right? Because there's always the constant comparison, but there is the ability to gather information. I would just encourage you, when you're gathering information, make sure that you're validating it in some way and that you're not you're making informed decisions for yourselves instead of what the masses are doing. So ignoring oral ties, it doesn't make the impact of them disappear. It just delays the treatment until the consequences are harder to fix. So here's what I want parents and providers to take away from this. Circumcision, it's a choice. It's not a necessity. And that choice should be informed. It shouldn't be automatic. Of course, there are parents that want to circumcise a child, and that's awesome. It's just that when we don't have the conversation about risks, benefits, medical treatment, it's just not fair to put a child through it, especially when there's no current dysfunction. So oral tie releases, frenectomies, they're not cosmetic. They're not. They're functional procedures that restore movement, relieve dysfunction, and, in my opinion, transform lives when we manage them correctly. Oral ties that can affect the whole system, from how we eat, how we speak and communicate, how we breathe, especially while in sleep, which is so integral to how we live as human beings, is the quality of our sleep. So if we're willing to surgically alter a newborn's body for prevention of a rare issue, why are we so unwilling to release a tongue that's visibly impairing life-sustaining functions like feeding and breathing? So let's stop calling oral ties controversial and start calling them what they are. They're treatable barriers to allowing a human to thrive, not just survive. And so in closing, thank you so much for spending time with me today on the Untethered Airway Health podcast. If this conversation challenged you, I know it does me, good. It should. Let's just start to question what we call routine care. Let's advocate for what's making improvements in life, not just what's culturally comfortable and normalized. So Give us a follow at Untethered Airway on Instagram or visit untetheredairwayhealthcenter.com to learn more about functional airway health. We have a ton of resources on our website, and I hope you'll take this journey with us. Follow along for the podcast. Until next time, stay curious, stay informed. Don't be afraid to ask better questions. Peace.
Thank you for joining us on the No One Told Me, the Airway Health Connection, the Untethered Way.
We hope you're leaving with new insights and feeling empowered to take charge of your airway health.
If you enjoyed this episode, be sure to subscribe and share it with anyone and everyone who needs to hear it.
To learn more or get in touch, visit us online at untetheredairwayhealthcenter.com.
Remember that when you breathe better, you live better.